Thank you everyone for attending. My name is Mary Beth Weber, and I am a faculty member in global health in at the Emory Global Diabetes Research Center. I am excited to introduce Dr. Angie Bengtson, a perinatal epidemiologist who leads a research program focused on the intersection of perinatal health and comorbidities. A large portion of her work examines the impact of HIV and its treatment with antiretroviral therapy on the development, management, and sequelae of cardiometabolic and mental health comorbidities during pregnancy, postpartum, and childhood. In addition, her work focuses on improving screening and treatment for gestational diabetes in resource-limited settings. Her research portfolio includes global work in Malawi and South Africa, as well as domestic work in America's Samoa and in Atlanta. Please welcome our speaker, and you can go ahead and get started, Angie.
Great. Thank you so much, Mary Beth, and thank you to everyone for being here today and for the invitation to talk with you a little bit about some of my work. So I'm going to focus most of my talk today around my work around gestational diabetes, but hopefully at the end we'll have a little bit of time to talk about some of my broader work in sort of cardiometabolic health and women's health. Let me just figure out how to advance. So just briefly a note on language for today. When I use the word women, I'm referring to people assigned female sex at birth, but obviously recognizing that the birthing population or the pregnant population encompasses more than just women. So I thought I'd share a little bit about myself to get started for a little bit of context. And I am trained as a perinatal epidemiologist. I did my training at UNC Chapel Hill, as Mary Beth mentioned. And my research is really focused kind of in recent years on this intersection of perinatal health with HIV infection and cardiometabolic comorbidities. So historically, I've done a lot of global work. I overlaid kind of my current projects with a map of global BMI rates for women. And so I've worked in places like South Africa with the University of Cape Town and Malawi, where I've worked with UNC Project for the last 15 or so years and have collaborations in Kenya. But since coming to Emory, I've also had a chance to expand some of that work more domestically, working with the STAR cohort, which I'll mention later, here in the Southeast United States, and then new collaboration with some colleagues from Yale and the University of Pittsburgh in American Samoa, which is actually a U.S. territory and is a domestic project, which turns out to be good in the current environments. So I put this up here with the BMI map just to kind of show that I think my work really spans both areas where we kind of have existing known high burden of obesity and cardiometabolic risk factors, as well as some emerging areas that we don't think about quite so often, in particular in sub-Saharan Africa. But this has increasingly been a sort of area of interest of mine, and I think a kind of growing concern for the HIV community. So in case you're wondering, how does a perinatal epidemiologist who works mostly in HIV come to be working in gestational diabetes? So this is a fair question. And really, I want to talk about kind of two different projects today, which is how I sort of got interested in the field of gestational diabetes, and in particular, thinking about how we might better screen and treat and optimize treatment for women in resource-limited settings. So first was really by way of HIV. I'm going to talk about some of my work on HIV and cardiometabolic complications in pregnancy, some of the newer ART drugs that have raised concerns about weight gain, and really about the lack of data we've had around kind of understanding cardiometabolic complications in the perinatal period for people living with HIV. That's led to some new collaborations and interest in a new project, the GROW study that I'll talk about, that's really focused around trying to understand some genetic determinants of gestational diabetes risk in order to try to optimize screening care and treatment. And then I also do sort of some other work more broadly in comorbidities and have some future work that we're kind of evolving right now around cardiovascular risk and postpartum health. So maybe at the end, if we have a few minutes, I'll talk about that a little bit. Okay, so just to kind of get us all, I probably don't need to do this for this audience, but just to have everybody start on the same page. Gestational diabetes is defined as any degree of glucose intolerance that's first detected in pregnancy. We typically screen for it at 24 to 28 weeks gestation, so getting towards the end of that second trimester. All pregnant people experience, some degree of glucose intolerance that happens naturally as part of pregnancy. If your beta cells can't keep up with that, that's when you would develop something like gestational diabetes. There are different ways to screen for gestational diabetes, and there are different ways to diagnose it. So in many parts of the world, they use a one-step process where everybody goes directly to getting a 2-hour oral glucose tolerance test. And then you would diagnose with something like the AID PSG guidelines. Here in the US, we use something called a two-step process where everybody gets a 50-gram unfasted glucose challenge test. If you fail that test, like I did in my current pregnancy, you are lucky enough to graduate to a full 3-hour oral glucose tolerance test. So I mentioned this in part to just say there's variation, but also that this is something that kind of comes into play when we're trying to compare prevalence data across countries and across studies. And often what happens in many resource limited settings right now is we don't have universal screening for gestational diabetes. So here in the US, we want all pregnant women to get screened for gestational diabetes. That typically doesn't happen in most other parts of the world. With limited resources, screening is much more risk-based. So I'll talk much more about that. Gestational diabetes affects about 8% of pregnancies in the United States. As I'm sure many of you know, it dramatically increases the risk of progression to postpartum type 2 diabetes. So it's not so much that getting gestational diabetes predisposes you to type 2 diabetes postpartum, but that it reveals this sort of underlying level of glucose intolerance that you have during kind of the stress test of pregnancy, which is correlated then with an increased risk of postpartum type 2 diabetes. Generally in the US, gestational diabetes has been increasing. So this is data from a study a couple of years ago, over 30 years, but looking all the way back to around 1980, we see that the rate of gestational diabetes has increased both overall and among Black and white people in the United States. There are important disparities racially and by ethnic groups. And when I talk a little bit about the GROW study, I'll talk about that. In particular, some of my work is focused on the very high rates of gestational diabetes among Pacific Islanders. So what about gestational diabetes and HIV? So there's really kind of mixed evidence about an association between HIV infection and gestational diabetes. Some studies have noted an association, some studies have not seen one. As I mentioned, it's a little bit complicated sometimes to try to compare across studies because people don't always have universal screening, or they use different types of screening or different diagnostic criteria. Most recently, or kind of in the last about 5 years or so within the HIV world, we've also had a newer class of drugs called integrase strand inhibitors, or INSTIs, that have become standard of care globally. INSTIs have been available in the US for a number of years, but became first-line treatment about 5 years ago in most resource-limited settings. And integrase strand inhibitors do a great job at suppressing HIV virus and are very well tolerated, but they have been associated with some weight gain. I'll show you some data related to that. So there's been a lot of questions circulating around what INSTI treatment is going to mean for both weight gain and sort of longer-term cardiometabolic risk, and very little data kind of from the perinatal period. At the same time, in resource-limited settings, which have the highest burden of HIV, we also have an increase in things like obesity and other gestational diabetes risk factors. So kind of in the background, we have increasing risk factors happening. There may be some HIV effects that we're interested in trying to understand, and then there may be these ART effects. So there's a lot of different things happening to try to disentangle, and a lot of my work has been focused on trying to understand what that means in the perinatal period and then postpartum as well. So outside of pregnancy, just to give a little bit more context, like why are we even worried about gestational diabetes among pregnant women with HIV? It's well known that people with HIV are at an increased risk of several adverse cardiometabolic health outcomes, including CVD, diabetes, metabolic complications, hypertension. So this has long been noted. And again, there's sort of differing hypotheses around what is an HIV-specific effect due to long-term inflammation. and what are maybe potential ART specific effects, and those can differ depending on ART class. But certainly this has been observed in many studies for aging cohorts of people living with HIV. So I mentioned there's been kind of a recent concern specifically around these INSTI drugs or integrase strand inhibitors. And the one that we worry most about in resource-limited settings, because it's part of first-line treatment regimens, is something called dolutegravir. So dolutegravir is an INSTI. It's been available, as I mentioned, in the US for a number of years, but around 2020, it was recommended by the WHO as first-line antiretroviral treatment for people living with HIV. So a little bit different than how ART treatment might work in the US, where it's a little bit more tailored to people and their particular needs, their resistance profiles, kind of what drugs they've been on. In many resource-limited settings, when the WHO recommends a first-line treatment, that's essentially what all ministries of health are going to get. That's what nearly everybody is going to be put on unless you fail that treatment, and then you need to go to a second-line treatment. So this means this is a widely used drug for people living with HIV, and it is also recommended as first-line treatment during pregnancy. This is what pregnant women, postpartum women, breastfeeding women get put on. So this is data from some of the early trials on some of the dolutegravir-containing regimen, and what we're looking at is change in body weight over time. So this is from the ADVANCE trial, which was a trial of about just over 1,000 people in South Africa who had not been on ART for at least 6 months and were initiating ART. And so we're looking at mean change in body weight from ART initiation through 96 weeks, comparing 3 different regimens. The ones in kind of the orange or red and blue contain dolutegravir, and the ones in green were the efavirenz-based regimen, which was the previous standard of care. So what was kind of noted very quickly about dolutegravir-containing regimens is it was leading to weight gain, and this weight gain was particularly prominent among women who were living with HIV. You can see that the rates are a little bit higher in the graph for women relative to men. So there's been a lot of interest, a lot of other studies and data. The ADVANCE trial came out back in 2019, so there's been a lot of other work looking at integrase strand inhibitors, looking at people newly starting ART, those switching ART, and trying to understand the mechanisms. Is this really a return to health effect? Is this really an effect specifically of integrase strand inhibitors? What about other kind of INSTIs? And I think largely what we've seen is that, some of these effects, this weight gain doesn't necessarily go up in a linear fashion. It's maybe shorter term. But certainly we have seen short-term changes in weight with starting or switching to an integrase strand inhibitor, and in particular, dolutegravir has been most widely implicated. So at the time, this was really important because, as I mentioned, WHO had just recommended dolutegravir as first-line treatment for all people living with HIV, and there was really no data on pregnancy, what was going to happen around gestational weight gain, what were the long-term implications. So I think the big question has been, there is some weight associated potentially with dolutegravir INSTIs. What are the implications clinically kind of moving forward? So that's where some of my work has tried to answer some of those questions for the perinatal space. And then just as I mentioned, there's sort of this, with all the HIV and ART specific effects, there's also these background risk factors that are changing. So obviously in places where I work, like South Africa and Malawi, even American Samoa, we're increasingly seeing populations leave their traditional diets, their traditional livelihoods, that might be more agricultural based or living in a village. They're moving into cities, their diets are changing, their physical activity patterns are changing, and we're seeing increases in obesity. I think within the HIV world, there still has sort of been this perception sometimes, particularly in resource limited settings, that, especially young women who are pregnant, are normal weight or may even be underweight, that we still have a lot of issues around undernutrition. And I think that just points to the complicated picture we often see in the places where I'm working in, particularly related to HIV as well, where you have kind of growing obesity, but you also can have food insecurity and other types of undernutrition that kind of commingle at the same time. And so disentangling those and their then cardiometabolic impacts can be quite tricky. Okay, so I just want to paint a little bit of a picture about sort of kind of where I work. I'm going to talk a lot about my work in South Africa first, and then I'll transition to American Samoa. But just to sort of dispel up front this idea that, women living with HIV who are pregnant are fundamentally undernourished or underweight, I should say, rather. At least in the areas where I work in South Africa, we have a very high degree of obesity. So this is data from a cohort study we did a few years ago, just over 1,000 women who were living with and without HIV. They were enrolled at their first antenatal care visit and followed for a year postpartum. And our study staff assessed anthropometry. Notably, this is actually from the pre-INSTI dolutegravir era. So the main thing I just want to highlight here is that women who are living with HIV, do tend to be a little lower weight. We see less obesity in that group, but it's not that they are it's not that they have a high proportion of being underweight or normal weight. Just about 25 to 30% of the cohort is in the normal weight category, very little underweight. And then for both women living with and without HIV, we see a lot of overweight and obesity. So this is not necessarily the case everywhere in sub-Saharan Africa or every place with a high burden of HIV, but in particular places like South Africa, which has the largest HIV cohort in the world, increasingly we see pregnant women coming in with prevalent obesity coming into a pregnancy already with an obese BMI. And not only are they coming into pregnancy obese, but they're also retaining weight postpartum. So this is from the same cohort, and we're looking at changes in maternal weight, BMI, and weight change by HIV status. And I just want to kind of draw your attention to these 12 months postpartum. So women who are living with HIV are lower weight at 12 months postpartum, but the median BMI is in the overweight category for women with HIV. It's in the obese category for HIV uninfected women. And maybe most concerning is relative to their weights at 6 weeks postpartum, on average, most women are gaining rather than losing weight in this postpartum period. So this kind of points, at least, for our group, to the idea that pregnancy and the postpartum period is really critical for thinking about how we might intervene and think about cardiometabolic risk. So we were interested in understanding a little bit more about some of this, and in particular, we're particularly interested in HIV and ART specific effects around glucose metabolism. We had the opportunity to do the cardiometabolic health and pregnancy, or CAMP study, which we were lucky to be able to do while dolutegravir was being rolled out. So we were able to look at both HIV and ART specific effects in South Africa. CAMP is a prospective cohort study of 400 women, evenly split by HIV status, that we did in Guguletu Township, which is a historically Black South African township outside of Cape Town. So we enrolled people at 24 to 28 weeks gestation because we want to screen them for gestational diabetes, and did follow up in the third trimester and then around 6 months postpartum. Everybody was screened for gestational diabetes and pregnancy, and then again at 6 months postpartum with a 2-hour OGTT. We also looked at things like lipids, anthropometry, blood pressure. I won't go through all of that today. Talk a little bit about gestational weight gain, and then looked at some associations with birth outcomes. So CAMP was unique in that it was actually one of the first studies that we had in an HIV-affected population, and in particular in the INSTI era in South Africa, where we had universal screening for gestational diabetes. Believe it or not, one of the big challenges is we just don't have very good prevalence data in most places because of the way gestational diabetes is usually done in a risk-based screening way. So this was sort of one of the first opportunities we had to look at what the true prevalence of gestational diabetes might be, how it might differ by HIV or ART status. Just a little bit about the cohort. So women were about a median of 30 years of age. As I mentioned, we intentionally enrolled them a little bit later in pregnancy so we could screen them for gestational diabetes. Women with HIV tend to be a little bit older, a little higher parity, and slightly lower BMI. That remained true into the postpartum period, but again, not huge differences here. And we were able to take advantage of the rollout of dolutegravir. So we had people who were on the previous recommended first-line treatment of efavirenz-based ART, those that then were switched when the Ministry of Health switched over to dolutegravir. And often in HIV-related studies, we're interested in understanding if people initiated treatment pre-conception or post-conception. Most of what I'm going to talk about today, we're going to focus on the post-conception cohort because we were really interested in understanding the effect of starting that medication in treatment and, what the implications of that might be. So we published our findings around gestational diabetes and AIDS a couple of years ago. And overall, we found that about 6% of the cohort had gestational diabetes, but we found a higher risk among women who were living with HIV. So 9% of people living with HIV developed gestational diabetes compared to 3% of women without. The adjusted risk ratio is about 3.9, and the absolute risk difference was about a 6% increase in risk. When we looked at our differences by ART regimen among those who started dolutegravir relative to those who had started efavirenz, we didn't see the same differences. So it's about 8% in the dolutegravir group with gestational diabetes and 6% in the efavirenz group. And, these are relatively small numbers, but again, some novel data here. And we think that, may suggest the differences are driven more by HIV rather than the ART specific effects. Just looking at the oral glucose tolerance test findings, you can see that really the differences by HIV status happened at that fasted glucose level. So most women were diagnosed, so everybody was getting a 2-hour OGTT, and we were diagnosing based on the IAD-PSG guidelines. So most women were diagnosed based on their fasting plasma glucose. I'll talk a little bit more about how we're thinking about that around screening, but could potentially have implications for screening. It's very challenging to try to give everyone a 2-hour OGTT in a setting like Guguletu outside of Cape Town. And so, one of the things our group's really interested in is how we can screen more efficiently. Of the 18 women who developed gestational diabetes, the distribution largely reflected kind of the distribution of ART and pre versus post-conception initiation within our cohort. So I don't think there's anything too surprising there. There wasn't a lot of postpartum glucose intolerance, which was a little bit surprising. We looked at both type 2 diabetes, impaired glucose tolerance, impaired fasting glucose, just given the very high rates of obesity, but again, relatively young, healthy cohort, and we were looking short term. So obviously we want to follow women longer to look at conversion to type 2 diabetes as well. But just 5% of women had any glucose impairment. And, there were 4 cases of diabetes, 3 of whom had gestational diabetes. So no surprise there, but I think highlighting that we really want to be able to find the cases of gestational diabetes, not just to treat them during pregnancy, but also to try to mitigate the risk of type 2 diabetes postpartum. So currently, in the CAMP study, we screened everybody for gestational diabetes. That's not currently what happens clinically in South Africa and in most other resource-limited settings where I've worked, for example, in Malawi or Zambia. Most people get risk factor-based screening. So are you obese? Have you had a previous large baby? Do you have a family history of type 2 diabetes? Those would all be examples of risk factors that might lead to screening. So this is some work led by a graduate student at the University of Cape Town and now being taken over by my colleague Flengi Madlala at UCT, where we're looking at kind of who do we miss based on this risk factor-based screening. So just to orient to this a little bit. So this is looking overall, and the colors indicate whether or not you had a clinical risk factor. So over here, we can see that, obviously most people in the cohort did not have gestational diabetes. Of the 374 without gestational diabetes, about 55% would not have been screened because they did not have a clinical risk factor. And about 45% would have been screened because they had a clinical risk factor but didn't go on to have gestational diabetes. Of the 25 who did have gestational diabetes, it's almost evenly split. About half would not have been screened, we would have missed them, and we would have got about 52% of them. So overall, not great sensitivity here. And you can see that it's a little bit better for women without HIV. We get about 57% of the people who did actually have gestational diabetes. It's a little bit worse for women with HIV. It's about 50% here, which probably reflects the fact that there's less obesity among women with HIV, and that's one of the risk factors. So I think the takeaway here is risk factor-based screening, makes a lot of operational sense when you are in a resource-limited setting, but it doesn't do a great job. We're not doing a great job of finding the women who have gestational diabetes. And that is particularly true for women with HIV, which is a concern if they have a higher risk of gestational diabetes. There was also some interest by a colleague in our group in looking at capillary blood versus venous blood. This has obviously been published on before, and I don't think this is surprising data, but it hasn't really been looked at in people with HIV. So here we're looking at the correlation between venous blood measures and finger pricks at the fasted time point. That would be the most relevant one for screening. And so not a great correlation overall, but it's particularly bad in women with HIV. So again, we've had a graduate student that's been interested in seeing if they could improve the predictive value of the capillary blood measure with looking at clinical risk factors. And I didn't include the data here, but I think the short story has been, capillary blood doesn't do great at approximating venous blood measures of glucose, and risk factor-based screening doesn't do a great job of finding people with gestational diabetes. So combining those, it doesn't really yield too much more, unfortunately. Both of those would be, sort of nice strategies for implementation, but just don't do a good job of finding the cases of gestational diabetes. So I think one question that has come up when I've shared these data before is, well, what about the gestational weight gain? You told me that, putting people on dolutegravir might lead to weight gain. Is it possible that you're just seeing more gestational diabetes among women with HIV because they're getting on dolutegravir, they're gaining weight, and it's leading to gestational diabetes? Good question. Not true in the CAMP cohort. So here we are looking at mean weight as well as the rate of gestational weight gain. So the dots are mean weight at different time points. These are self-reported pre-pregnancy, but measured at these other time points. And then the line is the mean rate of gestational weight gain over time. So you can see that women with and without HIV, women with HIV start a little bit lower weight, but they also tend to gain weight a bit more slowly during pregnancy than women without HIV. And we really didn't see many differences at all based on ART use in terms of gestational weight gain, suggesting gestational weight gain is not probably driving gestational diabetes within this cohort in particular. However, that doesn't necessarily mean gestational weight gain is not important or that everyone is doing great. One thing I just wanted to sort of highlight is we see a lot of suboptimal gestational weight gain within this cohort. So the Institute of Medicine, or now the National Academy of Medicine, has recommended guidelines for both the total amount of weight and the rate of weight gain in the second and third trimester for women based on their pre-pregnancy BMI. There are no specialized guidelines for women with HIV. So, while we see slower rates of gestational weight gain, there is no kind of reference standard for women with HIV to compare that to. So we're comparing it to women without HIV. So here we're looking at those National Academy of Medicine rate of weight gain standards, and they sort of define them as, are you below the recommended level, within, or above? And this is stratified by HIV status as well as pre-pregnancy BMI. So we see a lot of weight gain in the above the recommended range, almost 50 to 60% for women without HIV, but still 30 to 40% among the women with HIV. We also see a lot of weight gain below the recommended thresholds, and that's true across pre-pregnancy BMI categories. It's a little bit higher for women with HIV, but you see a fair amount of it for both women with and without HIV. So I think, again, this points to kind of this complicated picture where we see a lot of obesity, but we also can see things like food insecurity and other kind of issues around nutrition or food deserts, particularly that women might be experiencing during the perinatal period. So we've done a lot of formative work to try to understand this a little more, and recently put in a grant around an intervention to try to support healthy gestational weight gain in pregnancy and postpartum, that I'll talk a little bit more about at the end if we have time. One thing that I thought was really important, though, is like 97% of women report that the providers never talked with them about gestational weight gain. Women in South Africa are generally aware of the risks of things like high blood pressure in pregnancy or gestational diabetes. No one is talking to them about weight gain in pregnancy or postpartum weight loss. So again, potential public health intervention point there. Okay, so just kind of some next steps. So I think CAMP provided some novel kind of preliminary data suggesting women with HIV may have a higher risk of gestational diabetes than women without HIV in the current modern ART treatment area. But we definitely would need to confirm that in larger cohorts. There's been some similar studies in Botswana and a recent population-based study in the UK and Ireland that did not observe an association between HIV and gestational diabetes. Probably the populations most closely aligned would be Botswana. I'll just note the prevalence of gestational diabetes among women with HIV was the same in Botswana. It was 9% in both studies. It was just that women without HIV also had a fairly high prevalence. So I think part of disentangling this is understanding what the risk of gestational diabetes is in the population without HIV in a given setting as well. In our study, gestational diabetes affected 6% of pregnancies. That was similar to what we see in the US, but a little bit higher than reported in some sub-Saharan African studies, which may reflect sort of the higher burden of obesity that we see in South Africa. And I think really points to a need, we need better strategies to screen for gestational diabetes. So one of the things we're trying to explore within the CAMP cohort is looking at how whether we could use fasting plasma glucose along with maybe some better targeted, more sensitive risk factors like HIV status to try to target screening strategies a little bit more. As much as I'd love to have universal screening for everybody, that's probably not a reality anytime soon in this setting. So trying to think through what that might mean clinically and from a cost perspective. And then we also have some ongoing molecular studies trying to understand some of the molecular mechanisms related to HIV, obesity, glucose metabolism. And then, as I mentioned, we're thinking about interventions. So with that, I want to switch gears a little bit and just spend the last 15 minutes here talking about the GROW study. So this is gestational diabetes related outcomes among American Samoa women. So we're moving all the way from South Africa now over to the Pacific to American Samoan. And this is a study I got involved in because of my work in South Africa with HIV and gestational diabetes. I met some collaborators that have done a lot of work trying to understand gestational diabetes risk among Pacific Islanders, particularly in American Samoa. And while it is a very different setting, there are a number of corollaries with my work in South Africa. High burden obesity in the population, a lot of sort of strong cultural preferences for larger bodies, and some of the similar resource constraints in terms of care and treatment. So this has been kind of a fun natural extension to some of my HIV-related work in a non-HIV infected population. So for those that don't know, and many of you probably do, there's very high disproportionate risks of both gestational diabetes and type 2 diabetes among Pacific Islanders. Some of the preliminary data from our group, again, we're in American Samoa, we don't have great prevalence data, we don't have great routine screening all the time, but from a recent pilot trial that one of my colleagues did, actually around a gestational weight gain intervention, 42% of women who were in her trial and everyone was screened had gestational diabetes. So that's over 4 times the US overall rate. And as I've already mentioned, there's a very high risk of conversion then to type 2 diabetes. Despite a lot of work on diabetes and gestational diabetes in recent years, Pacific Islanders are often a small group, difficult to study their risk factors, and so have really been sort of left out, I think, of a lot of the research in trying to understand some of the particular risk factors that might be relevant for this population in terms of both intervention and prevention. And so that's been some of the motivation I'll talk about for this growth study coming up. So the group of collaborators that I've been working with, they've been working in American Samoa, an independent nation of Samoa, for the last 20 plus years. And a lot of their work has focused on genetic determinants of risk. I'm not a genetic epidemiologist, so forgive me if you have genetic questions. I'm probably not the best person to answer them. But their work has identified this novel missus variant in the CREBRF gene. And what's been really unique about this gene is widely or it's very common among Pacific Islander populations. About 45% of American Samoans have at least one copy of the GA or AA genotype, so at least one A copy. And what's unique about CREBRF is it is associated with this higher risk of obesity, but this lower risk of diabetes. So something about it has evolved so that there's very large body types in American Samoa and Pacific Islanders in particular, but it has evolved in a way to be protective against diabetes risk. So far, there's been one study on CREBRF and gestational diabetes risk. It was a small study in New Zealand of a Maori population, 122 women that were part of a nutritional intervention. And so some interesting preliminary data over here on the left showing that 0% of people who had an AA genotype developed gestational diabetes. There was a couple of people who with AG genotype that did, and then a much higher risk of gestational diabetes in people without an A copy of this novel missus variant, the GG genotype. So we were interested in American Samoa in trying to understand whether this potential effect of the CREBRF gene on gestational diabetes holds up in a larger, more generalizable population. What's the impact in the transition to postpartum diabetes? What is the mechanism of action? And is there an impact on birth outcomes? And so some of our preliminary work suggests that this is OGTT curves from women without gestational diabetes. People that have either the AA or AG genotype tend to have their glucose doesn't get quite as high, and they tend to have a better insulin response, particularly kind of early on in these OGTT curves. So suggesting they may have a better first phase insulin response that is correlated with the genotype. So we're wanting to explore these questions in GROW. GROW is a prospective cohort study of 350 women. We're going to be enrolling women early in pregnancy, 10 to 14 weeks, following them through 18 months postpartum. We will exclude people who have 1-2 diabetes, but not those with pre-diabetes, just because it's so prevalent in this population, and we think that would make our results not generalizable. We are just enrolling our first GROW participant this week, so I'm going to talk a little bit about the study, but I unfortunately don't have data to share yet, but it's been really exciting to get this study up and running. It's led by myself, Dr. Erin Kershaw, an endocrinologist at the University of Pittsburgh, and Dr. Nikki Hawley, who's a biological anthropologist at Yale. So what is very unique about GROW, and I think we're really excited about, is we are going to be, this is the different time points that we have study visits with women, but we're going to really be able to well characterize glucose metabolism in the perinatal period in this high-risk population. So we're doing frequently sampled oral glucose tolerance tests, looking at HbA1c, and then all participants will get continuous glucose monitoring for 10 days at 3 time points during pregnancy and at 2 time points postpartum. Of course, we'll do a host of other measures and questionnaires as well. So just a note on the continuous glucose monitoring. So for those of you that work in diabetes, this may seem like very routine standard of care. This is not typically used in pregnancy. It's not a tool that is considered standard of care. maybe outside of people with type 1 diabetes in pregnancy. So this is a unique opportunity, we think, to characterize glucose profiles for women who develop gestational diabetes and those that don't in this high-risk Pacific Islander population. And then, of course, we're interested in looking at differences in glucose profiles by genotype over time. So just briefly, some of the planned analyses. So aim 1, we're going to be looking at associations of CREB-RF with gestational diabetes. So looking at effects on incident gestational diabetes, and then plasma glucose at the different time points. In the OGTT, we'll look at OGTT outcomes at 10 to 14 weeks and 32 to 36 weeks. And then we'll look at glycemic patterns and glycemic control based on the CGM data. And then we're also interested in looking at kind of how glucose patterns may differ by genotype among specifically those women who are diagnosed with gestational diabetes. In aim 2, we're going to be looking at how CREB-RF affects glucose homeostasis and then conversion to postpartum, either pre-diabetes or type 2 diabetes. So we'll look at kind of return to A1C from the early pregnancy period and fasting glucose. We're also going to be using kind of a cool newer method called Bayesian consensus clustering to try to kind of combine OGTT data over time to look at different patterns and how they may differ by genotype. And then we'll look at incident pre-diabetes and type 2 diabetes, as well as be able to look at how these CGM profiles, potentially from pregnancy, whether or not they're predictive of conversion to type 2 diabetes or pre-diabetes postpartum. Aim 3, we have a sort of large, complicated mediation analysis, but the real interest here is trying to understand the extent to which improvements in insulin secretion associated with a CREB-RF genotype may be protective against gestational diabetes risk or type 2 diabetes. So we're going to be accounting for changes in body composition, because you may recall I mentioned CREB-RF is associated with larger body types, but lower diabetes risk. As well as potential changes in insulin secretion using the dispositional and Strimble index. And then finally, in aim 4, improved insulin secretion may be good for reducing gestational diabetes or postpartum type 2 diabetes risk, but it may not be great for birth outcomes. So we're going to be exploring how some of these effects may increase or may affect things like large for gestational age, cesarean delivery, or neonatal hypoglycemia. So, some of the things we're really interested in thinking about here is CREB-RF is a unique opportunity in Pacific Islanders. As I mentioned, it's well represented in the population. About 45% of the population have at least one copy, one allele. And so there is potential screening implications for this. So, one of the things we're hoping to find out is, should we be preferentially screening or screening earlier based on CREB-RF genotype? Given the high risk of diabetes within this population and high rates of pre-diabetes for women coming into pregnancy, should we be thinking about different diagnostic thresholds? And can we think about CREB-RF genotype as a way to guide treatment? If we do see evidence of improved kind of first phase insulin secretion, can we then recommend particular treatment during pregnancy to try to mimic that to get the best outcomes? And then if there's any pediatricians in the group or people who do kids health, don't worry, we haven't forgotten about the kids. We just put in an R01 or a couple months ago, one of my colleagues, to study the impact of maternal fetal genotype together on body composition and glucose metabolism in children. So that should be reviewed next month. Okay, so just in the last minute or two, I want to talk a little bit about kind of some current and future work around, ways that we can support cardiometabolic health more broadly for women during their reproductive years in resource-limited settings. So my work has kind of been organized in some of these, in kind of these 4 key areas. So in terms of supporting healthy gestational weight gain, I mentioned or alluded to that we had a grant that in any other time I think would have got a fundable score last week, but is in South Africa. So it doesn't sound like it's going anywhere anytime soon. But we've developed a group-based prenatal care intervention to help increase education around healthy eating and to try to address both suboptimal gestational weight gain as well, or gestational weight gain that's too low, as well as gestational weight gain that's too high, with continued support in the postpartum period. So a fun project that I'm excited about, Elizabeth Rhodes, who's also a diabetes center member, is involved, and I hope we get to do it. I didn't talk about this part of my work at all today, but I do some work sort of on psychosocial and mental health support as well, as a barrier to addressing HIV and cardiometabolic complications. So I have a project in Malawi where we're working to improve, or we're looking at intervention to improve perinatal depression, to support ongoing engagement in HIV care. And I think there's a lot we could learn there that might help us support women who are dealing with other chronic conditions like gestational diabetes during pregnancy, to help them be adherent to treatment, and then, postpartum, to reduce risk as well. So I already talked a little bit about my work in American Samoa, and some of our interests in South Africa around trying to improve gestational diabetes screening. And then just briefly, so I've started working quite a lot with the STAR cohort here in the United States. STAR is a cohort across 6 sites of reproductive age women who are living with and without HIV in the Southeast United States. And we've been, I have a couple of different grants. We have an R1 going back in today or tomorrow, hopefully. And then we were part of a U19 application to refund the STAR cohort, focused on understanding why women with HIV, and particularly women with HIV at younger ages, have a higher risk of CVD, and trying to look at some kind of novel, non-invasive measures of vascular endothelial function to understand some of the pathogenesis, and understand kind of earlier intervention type points. So that's been some exciting work that's outside the diabetes world, but kind of more broadly in the cardiometabolic risk world. So I will end there, just with thanks to many folks who've been a part of this work here at Emory, at UCT, Brown, University of North Carolina. I mentioned my colleagues at Pitt and Yale, as well as the funding sources that have funded this work. So thank you so much. I'm happy to take any questions people might have.
Thank you so much, Dr. Bengtson. We do have a question in the chat.
Yeah.
What are your thoughts on early diagnostics of GDM? How can we have novel biomarkers and that could be clinically relevant, and approval hurdles any?
Yeah, this is a great question. I think that there's sort of 2 pieces to it, right? I think there's the question of, should we be screening earlier? And I hope I'm not misinterpreting the question. So we currently don't screen for gestational diabetes until 24 to 28 weeks in pregnancy. There's, work going on in the US currently, and in other studies looking at early screening. The data so far hasn't suggested that we should be screening necessarily earlier. But I think there's still this open question in groups of populations that are very high risk, whether early screening may be relevant. So in a place like American Samoa, where you have extremely high rates of obesity, extremely high rates of prediabetes, screening earlier may be beneficial. That's one of the things we're hoping to learn and grow. In terms of better strategies for screening, I think there's several different ways we might think about it, or kind of different ways we've thought about it, at least within our research group. One, with existing tools, can we do better, right? Like with an OGTT, can we find more sensitive risk factors? Can we look at fasting plasma glucose? Like, can we do better with the tools that we have? But there's no question we also need better tools. I would love if we could figure out, a biomarker that we could do early in pregnancy or even later in pregnancy that was strongly correlated with risk of gestational diabetes. And then we would only have to screen, some small percentage of the population who had, a biomarker above that level. That's one of the things I'm hoping we might, there's biomarkers looking at that. I think you can also look at glucose patterns early on. So that's one of the things we're also hoping to learn and grow, is whether we're going to have early continuous glucose monitoring data. So we'll get an early look at glucose dynamics for people in pregnancy. And, one of the questions is, are they predictive of type 2 diabetes postpartum, but also gestational diabetes? So I think it'd be very relevant if we had novel biomarkers. I think the challenge is just finding them and then making them clinically available in resource limited settings. I think the third thing we can do, kind of in line with the first thing I mentioned, is can we find better risk factors to look for? So we know that in a place like South Africa, obesity isn't a great risk factor for finding people with gestational diabetes, particularly kind of the complicating factors of HIV. But in a place like American Samoa, your CREBRF genotype might actually be a really good indicator of your gestational diabetes risk. So thinking more about understanding genetic determinants of risk and whether we might be able to integrate that into some of our look at biomarkers or risk factors, or being able to genotype populations so that we can more effectively target screening in some resource limited settings.
All right, but we don't have any more questions in the chat. If anyone has any questions, please raise your hand and unmute yourself or type it in the chat.
I have a question, actually. When you're thinking about interventions for women with HIV at risk for GDM or already having GDM, do we need to think of interventions that are different than in women without HIV who are at the same risk?
Yeah, that's a great question, Mary Beth. I think there's sort of two ways to think about it. But I would say that I guess the way I would think about it is a lot of times we sort of jump to thinking about tailoring specific interventions for women with HIV, right? And we kind of forget that, like in particular around cardiometabolic risk, or let's just take something like gestational weight gain, there's a huge amount of suboptimal gestational weight gain happening in HIV uninfected women. So we've sort of taken, with the work that I've been doing, taken the stance that we need to include both. And we need to understand whether there are different drivers, maybe potentially different moderators or mediators for effectiveness within the different populations. I do think there are different considerations, right? Like people with HIV are managing a chronic condition while pregnant. They have adherence to daily medication that they need to have. They may have other kind of psychosocial concerns going on, which we know are associated with gestational weight gain related to a recent diagnosis or concerns about passing on to a child. But I think that we shouldn't focus on them at the exclusion of women without HIV. There's a clear public health need, I think, to start addressing some of these, the high rates of obesity and pregnancy and postpartum weight retention in resource-limited settings. And I think, frankly, we've been a little slow to do that. So I think we need to start thinking about interventions that, are relevant from an implementation standpoint within these settings, are going to be feasible and acceptable to populations. And I didn't really talk about it. We've done a whole kind of set of formative work around some of that in South Africa, that are thinking about the impact of HIV, but take a kind of broader public health approach to thinking about some of these.
All right. Well, if we don't have any more questions, Dr. Bengtson, thank you so much.